people from Brazil or?
No,
Well, no,
I know Jonathan
Mhm.
online.
Because of my I did adult MSK, I sort of am a little bit in the SSR world, a little bit but mostly in the peds. But that's how through OCAD is this. Do you know of OCAD? I'm sure you have heard of it because you're on it now. But
Yeah, I've heard of it. I don't know a whole lot about it though.
It's a pretty large international MSK case sharing forum. There are like over 1,500 people from, I have to check, lots of countries. So anyway,
Excellent.
Okay.
Yeah, it is a great team. OCAD is the best.
Awesome. Well, thanks for having me.
Yeah, so it's 2 o'clock in Brazil. Hello, everyone, and thank you all for joining us today. We're back after a 2-month break, and we're excited to have you all here. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Sergio Viana, Dr. Jonathan Summit, and Dr. Catherine Mills. This session will focus on pediatrics. The speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com. And also on the YouTube channel of the Radiology Society of Rio de Janeiro. Just a quick reminder, attendees have not been given the permission to screen record any of these presentations as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and with that, I will kick off the session. It's my great pleasure to introduce my dear friend, Sergio Viana. Dr. Sergio Viana is a practicing musculoskeletal radiologist based in Brasília, Brazil. He is a member of both the International Skeletal Society and the Brazilian College of Radiology. He has a particular interest in pediatric musculoskeletal imaging and rheumatology imaging. Over his career, he has co-authored numerous articles, books, and book chapters, and has been a guest speaker on MSK imaging at national and international conferences for over 20 years. In addition to his clinical and academic contributions, he is actively involved in continuing medical education through his Instagram account, which is at Advanced MSK. Please, Sergio, share your screen.
Thank you, Eleni. Just 1 second. Is this working?
It is. Thank you.
Okay. Well, hello, everyone. Thank you, Eleni. Thank you, Hilary, for having me once again. It's always a pleasure to be part of this amazing case presentation series. And today I'm going to present the case of a 12-year-old girl diagnosed with sacroiliitis since she was 9 years old. Over the course of 3 years, she had several MRIs consistently reported as showing bilateral sacroiliitis, like this one. However, her rheumatologist asked for a second opinion because she disagreed with the diagnosis, and I reported the imaging findings as normal. In these annotated STIR images, we can see white asterisks indicating the presence of the normal sacral apophysis, typical of immature sacroiliac joints, which appear as dark gray areas. We also see yellow arrows pointing to hyperintense lines along this apophysis related to the so-called flaring phenomenon in the sacrum, which we'll discuss pretty soon in this presentation. And in addition, gray arrows point to the counterpart of these hyperintense lines at the iliac surfaces, which display similar thickness and signal intensity. It is important to note that in the last image, the sacral lines of high signal extend downwards beyond the sacroiliac joint surfaces, indicating that it cannot correspond to subchondral bone marrow edema, simply because there is no subchondral bone here, as there is no joint at this point. So during this past time, this girl was misdiagnosed with bilateral sacroiliitis related to misinterpretation of imaging pitfalls arising arising from normal structures in the immature sacroiliac joints. So why is relevant to address this topic? First, the appearance of the normal immature sacroiliac joints is less studied than that of their adult counterparts. There are not many references in the literature, and most of them are quite recent. Second, similar to the epiphysis, there are structures in the immature sacroiliac joints that are absent in the adult and undergo a series of transformations during their development related to their maturation and eventual involution. Thus, one must be aware of the normal structures, peculiar findings, variants, and pitfalls on imaging studies before being able to diagnose abnormal findings of the immature sacroiliac joints. From the above, it follows that an anatomical basis is necessary to understand the imaging findings. This anatomy, however, is very little known outside of pediatric musculoskeletal radiology circles. The most important difference between immature and adult sacroiliac joints is the presence of cartilaginous apophyses in the sacral wings, which are typical of the growing skeleton, but often unknown to the radiologists. There are two types of this apophysis. The first are the segmental, which connect the sacroiliac joints to the sacral foramina at the level of the rudimentary discs, thus presenting a transverse course. And the second type are the lateral apophyses, the most relevant in imaging assessment, since they are longitudinal and therefore continue along the sacroiliac joints. This image is quite appropriate to understand what we are discussing today. We can see the hyperintense articular cartilage indicated by the white arrow, and the black arrow points to the lateral apophysis, which appears gray along the articular surface of the sacrum. This means we have not just one, but two different types of cartilage at the immature sacroiliac interface. The segmental apophyses, one of them pointed by the arrowhead, are also hyperintense. In this case, featuring coronal stir and pre and post contrast T1 weighted images with fat suppression, the asterisks indicate the longitudinal and transverse sacral apophysis, as well as the typical appearance of the flaring phenomenon present along this apophysis and also at the iliac surface as thin lines of high signal in stir that show physiological contrast enhancement. From the last slide, we can infer that flaring is the most important pitfall when assessing immature sacroiliac joints on MRI because it appears as thin, homogeneous, and symmetric areas of high signal intensity on fluid-sensitive sequences along the sacral apophysis, thus simulating bone marrow edema. This high signal is similar to that of the metaphyseal primary spongiosa and probably has a similar meaning, representing ongoing endochondral ossification. One of the more important clues is that flaring is present along the entire longitudinal extension of the sacrum, including the portion inferior to the sacroiliac joints, and adjacent to the segmental processes, which means areas that are not in a subchondral location, and therefore it cannot be osteitis. In addition, flaring may also be present at the iliac borders, just like in the previous image, but it is always less frequent and invariably less intense and less extensive than in the sacrum. Flaring is especially pronounced in these stir images of another child and might be misinterpreted as osteitis. However, once again, note how thin it is and how its distribution is typically symmetrical and bilateral along the sacral apophysis, which we can see indicated by the arrows and also present in the lower portions of the iliac surfaces, extending inferiorly into the sacrum, beyond the lower limit of the joint surfaces, thus demonstrating that it cannot be subchondral bone marrow edema. Finally, there are some other physiological differences between the sacroiliac joints of children and adults on MRI. One must keep in mind that the subchondral cortex of the sacroiliac joints may be irregular in children, especially on T1, and notably in the upper quadrants and at the iliac borders, typically without bone discontinuity, unlike erosions which, by definition, cause cortical break. In addition, joint space delineation is more difficult in children than in adults, as the ongoing ossification leave the joint margins blurred and irregular, especially on T1 images. These are images from a paper from a respected Belgian group. In the upper row, coronal T1 images demonstrate how hard it is to delimitate the joint space in this sequence, mostly in the second image, in which it's very difficult to distinguish the cartilage from the subchondral bone because this interface is hazy. The arrows in the third image point to the physiologically irregular contour of the immature iliac surface, a finding also more pronounced in T1. And in the stir image, the arrows point to our friend, the classic flaring phenomenon. This is a 12-year-old boy who had been treated for spondyloarthritis for 3 years. The findings described in this MRI from a year before included a hazy bone cartilage interface on T1 weighted images, high signal intensity of the sacral subchondral bone on stir, with contrast enhancement and irregular contour of the iliac articular surface, more evident on the CT-like sequence. Even though they were indeed present, such findings, as we have discussed today, are normal in the immature skeleton, corresponding to physiological haziness of the bone cartilage interface related to active osteogenesis, flaring phenomenon, and physiological irregularity of the iliac surface, lacking the cortical discontinuity that would be typical of erosions. In conclusion, the MSK community is still in the process of mastering the normal appearance of the immature sacroiliac joints on sectional imaging, and many MSK radiologists, if not most, are not acquainted with their peculiar aspect. Flaring is by far the most important source of misinterpretation of pediatric MRI, and it's very likely that we may be overcalling sacroiliitis in children. Thank you very much for your attention.
Thank you, Sergio.
Hi, everybody. I'm Hilary Humans. It's my pleasure to introduce Catherine Melks, who's the Medical Director of Pediatric Musculoskeletal Radiology at Nationwide Children's Hospital in Columbus, Ohio. She completed her residency training at Wake Forest University in Winston-Salem, North Carolina, and went on to complete general diagnostic pediatric radiology fellowship at Nationwide, followed by a second pediatric musculoskeletal and body radiology fellowship at Nationwide and Texas Children's Hospital. Dr. Milks is an assistant professor of radiology at The Ohio State University, adjunct professor of radiology at the University of Toledo, and adjunct professor in the Department of Pediatrics Rheumatology at Nationwide Children's Hospital. Her most recent research publications look at the use of non-contrast MRI FLAIR fat-suppressed sequence to detect synovitis in the pediatric knee. Okay, it looks like Catherine's already ahead of me. Go ahead.
All right, well, thanks for having me today. I'm going to talk about imaging in pediatric rheumatology, wisdom in radiographs, and I have 3 cases here to share this morning, or this afternoon. All right, so here's a 5-year-old female who was referred to orthopedics for limited range of motion of the right wrist. An astute clinician obtained bilateral hand radiographs, which allow us to easily compare the symptomatic to the asymptomatic side. And you can see that on the symptomatic side, on the right, there is advanced ossification of the carpal bones as compared with the left. If you compare this to reference bone age standards, you'll see the left side is normal for a 5-year-old female, but the right side is advanced. What else do we notice? Let's mag up on the carpals, and you can see that the shape of the carpals on the right is unusual. How would you describe it? Well, the ossification centers of the carpus are not nice and smooth, but have angular margins, sort of sharp and squared. And in addition, there's subtle demineralization of the carpal bones and surrounding osseous structures, as well as asymmetric joint space narrowing of the radiocarpal interval. So this is the first point I want to illustrate. The normal carpal ossification centers in young children are round. Think marbles. And they should never be square or have angular margins. Think blocks. For this appearance, I use the term multangular, meaning many angles, and this appearance indicates pathology. More specifically, it indicates the effect of chronic hyperemia on the bone, causing it to ossify prematurely and in an angular fashion. So let's review the findings. We have demineralization on the right, asymmetric carpal ossification with multangular or angular contours to the carpal bones, radiocarpal joint space narrowing, and then together with the clinical scenario, this was consistent with juvenile idiopathic arthritis, or JIA. So the patient really didn't need any additional imaging for diagnosis, but did receive an ultrasound as a baseline and to which future post-treatment response can be compared. So on the top, you have a longitudinal image of the wrist with the proximal on the left and distal on the right. And you can see the arrows indicating abnormal hypoechoic tissue emanating from the dorsal radiocarpal and intercarpal joints. On the bottom image, you can see there's increased Doppler signal within these areas of abnormal hypoechoic tissue, consistent with active synovitis. And by rheumatology ultrasound scoring guidelines, this would be grade 2 synovitis. Finally, the patient did receive an MRI, which corroborates the findings and better demonstrates small rat bites, as I like to call them, out of some of the metacarpal bases and carpal bones on our 3D gradient echo sequences. These are consistent with erosions. On the image on the right, our sagittal T1 fat-suppressed post-contrast image shows enhancement and thickening of the synovium. So there is a differential diagnosis for chronic hyperemia of the bone. Inflammatory arthritis is probably the most common cause, but hemophilia can cause changes that are nearly identical on radiograph. However, it's important to note that it only really affects the elbows, ankles, and knees in children, and in that order. So wrists are out. They never bleed into their wrists. And chronic joint or bone infections could also be a cause of chronic hyperemia, but less common. So the takeaway point from this case is that squaring of the carpals and advanced bone age are signs of chronic hyperemia, and unilateral in the wrist in the absence of any findings of infection are pretty much diagnostic for JIA. All right, so here's an older patient, 16-year-old male, who presented with chronic knee pain and swelling. And we have AP and lateral knee radiographs, which at first glance appear somewhat normal. But as we look a little closer, could I convince you that there may be a small osteophyte forming along the medial femoral condyle? It's a little bit too squared here for my liking. And on the lateral view, there's a large effusion, not only within the suprapatellar recess, but tracking inferiorly and displacing Hoffa's fat pad away from the bone. So sagittal T2 fat suppressed image on the left and our T1 fat suppressed post-contrast image on the right in the same patient confirms the large effusion and marked synovial hyperenhancement and thickening consistent with synovitis. On the T2 weighted sequences, you can see there are some areas of irregular cartilage thinning medially along the femoral condyle, here and here, indicating early cartilage loss from chronic synovitis, which also explains the small osteophyte that we saw forming along the medial femoral condyle, cluing us into this pathology. So the point here is that in older children, radiographic signs of JIA may be subtle, but osteophytes are never normal in children and indicate joint pathology. So please avoid using the term degenerative joint disease. Children should not have DJD, and findings of joint space narrowing or osteophytes should really prompt a differential of post-traumatic, post-infectious, chronic inflammation, or hemophilia in your impression. So to summarize, some of the findings of juvenile idiopathic arthritis on plain films include, of course, joint effusion, but in children, we're looking for advanced bone age, enlargement and squaring of the metaphyses with or without small osteophytes, again, indicating chronic hyperemia. Periarticular osteopenia is common to children and adults, and erosions, while we do occasionally see them, are quite rare in children. MRI classically shows us synovial thickening, hyperenhancement in the active and acute setting, and then in chronic disease, we might see cartilage loss and erosions. Where are we going with imaging of JIA? Well, at our institution, we hope to decrease the use of contrast in suspected JIA of the knee by suppressing fluid signal in the joint, thereby making the synovium hyperintense in signal and visible without contrast. The image on the top right shows a conventional T1 fat suppressed post-contrast image, and you can see the hypertrophic synovium, as well as the image on the bottom is our non-contrast flare image with suppression of fluid and fat, allowing us to see the synovium just as well as on our post-contrast imaging. So you can read more about it in this article if you are interested. All right, third and final case. This is our 16-year-old female who presented with autism and hip pain, and radiographs of the pelvis were performed. So as we look at these, we can see there are some cortical erosions at the inferior pubic rami bilaterally, right here. So you may be saying, well, this is not intra-articular pathology, couldn't be JIA, but what does it indicate? Well, it is at the origin of the hamstring tendons. Additionally, we can see a small bony excrescence here at the gluteal musculotendinous insertion on the greater trochanter. We keep looking. I think you can see that there is some sclerosis of the bilateral sacroiliac joints, predominantly involving the iliac side, as well as some periarticular lucencies and irregularities suggesting erosions. So the patient did go on to get an MRI, and our axial T2 fat suppressed image here shows bone marrow edema or osteitis of the bilateral greater trochanters and edema at the gluteus medius insertion there. Coronal stir sequence of the pelvis again demonstrates marrow edema and erosions at the bilateral hamstring origins. And finally, our axial sequences demonstrate multiple erosions and bone marrow edema about the bilateral sacroiliac joints, with a small fatty lesion along the left sacroiliac joint here as well, indicating both acute and chronic sacroiliitis. And this is consistent with enthesitis-related arthritis. So enthesitis-related arthritis, or ERA, is a subtype of JIA. The imaging findings will show enthesitis often, in which case we are looking for cortical erosions or hypertrophic bony changes at ligamentous and tendinous attachments. Sacroiliitis is often present, but not always, and synovitis may or may not be present as well. However, there are additional clinical criteria that are required for the diagnosis. So the take-home point from this case, again, is that enthesophytes are not normal in children. Erosions at ligamentous and tendinous attachments in a child should raise concern for JIA with ERA subtype, especially when it's bilateral and symmetric. So in conclusion, radiographs have a really important role in the assessment of JIA. However, many of the clinicians feel that they're often worthless. However, when they are abnormal, they can be very helpful. Unilateral advanced bone age is a sign of chronic hyperemia, and children should not have degenerative joint changes. Degenerative appearance should prompt a differential diagnosis, again, either post-traumatic, infectious, or inflammatory. Thank you.
Catherine, that was absolutely beautiful. Thank you. I put some questions for you in the chat. Check it out. Okay, and now, bed and cleanup. Dr. Jonathan Samet is an associate professor of radiology and orthopedic surgery at Northwestern University Feinberg School of Medicine, primarily based at Ann and Robert H. Lurie Children's Hospital of Chicago, serving as the division head of body imaging and section head of musculoskeletal imaging. He also works in the adult musculoskeletal radiology section at Northwestern Memorial Hospital. He trained in diagnostic radiology at Northwestern, followed by subspecialization in MSK radiology at Johns Hopkins Hospital, and is also board certified in pediatric radiology. He studies nerve imaging with MRI, neurography, and ultrasound, rapid MSK imaging, and quantitative MRI for bone marrow composition. I'd like to add that I consider Dr. Samet one of my go-to MSK pediatric consultants, for which I'm very grateful. Okay, Jonathan, take it away.
Thank you so much, Dr. Humans, and your cases are always the hardest cases, so I always appreciate getting those consults. Well, thank you, everyone. Thank you for inviting me. This is going to be showing you some interesting PEDS MSK infection cases, and what you're going to be seeing mostly are images from our rapid MSK infection protocol, which is kind of a newer protocol where we are imaging children in the least invasive way, without contrast and without sedation. So that's not the focus of the talk, but I just wanted to let people know that. So starting off with just a basic case here, we're going to see a 5-year-old patient with concern for infection, and we're showing you the T1 and the stir images of the right ankle. And what you notice is that there's a little bit low signal on the T1 centered in the metaphysis. And then on the stir image, we have high signal in the metaphysis as well, and some surrounding periostitis. So this, of course, is acute osteomyelitis of the right tibia. And what I like to highlight for people who are more adult MSK rads is that in pediatrics, a lot of our osteomyelitis is typically bloodborne. So you have a patient with bacteremia, the infection will spread to any areas of high blood flow. And so because the developing bone is very vascular, so the growth plates, infection loves to go to the metaphyses of long bones, for example, and right next to the growth plate. And so it's a bit different than when I practice on the adult side. Most of the cases of osteo I'm seeing are contiguous spread. So for example, diabetic foot adjacent to an ulcer, but in pediatrics, it's often from bacteremia. And of course, you're going to expect low signal on T1 and high signal on T2. I'm not quite as strict about the signal characteristics as I am on the adult side with seeing, very low marrow replacement on T1. Because in pediatrics, again, if you see signal in the metaphysis in a patient who is clinically suspected, any signal is pretty concerning, even if it's a subtle signal there. Moving on to case 2, another patient with concern for infection. These are T2-weighted sequences with fat suppression. And we have a little bit of signal in the metaphysis, but not super impressive. But we're noticing something here that is bowing off of the cortex. It is a fluid collection with a black rim of tissue. This is the periosteum. And on the axial image as well, you can see that this fluid collection is held in by this periosteum. Notice that at the level of the growth plate, this periosteum is tacked down much more tightly. And so usually the collection is tapers at this point. So this is a subperiosteal abscess. And this, just as any abscess, might need to be drained. So when you're reading PEDS MSK cases, you really want to comb and scroll through the bones on the axials and the sagittals to see if you see any lifting of the periosteum to diagnose a subperiosteal abscess. Now, we never see subperiosteal abscesses on the adult side. And one of the theories is that periosteum has looser attachments to the cortex in PEDS, and that will allow the infection to basically lift up the periosteum. This will often need drainage, so it's very important, again, to look for these complications of osteomyelitis. And if the infection is very advanced, it can actually break through the periosteum into the soft tissues. So that's subperiosteal abscess. Another case here showing you 2 different patients where we're seeing a T1 post-contrast. This is from a conventional sequence protocol, not our rapid. And you can see rim-enhancing fluid collections and the thigh musculature. And on this T2 fat-suppressed sequence, we see 2 things. We see an intramuscular fluid collection, and we also see a thin subperiosteal collection. And note that this is non-con, so we're still able to diagnose subperiosteals on that. So I'm showing you soft tissue abscesses. Again, this is another thing we have to look for as a complication of osteomyelitis in kids. This would be the intramuscular abscess in this case. And this has 2 things, a subperiosteal abscess and an adjacent muscle abscess. This next case is showing you what I think is important to add to your infection protocol. So diffusion-weighted imaging. And we're seeing an area of high signal on the DWI and corresponding low signal on the ADC, which would indicate restricted diffusion of water. And in the setting of infection, this is compatible with an abscess. So abscesses, as you probably know, cause restricted diffusion. Here's another example. This is a subperiosteal abscess of the femur, bright on DWI, dark on ADC. Here showing that other abscess that we had on the T1 post-contrast. You can see it's highlighted very nicely on this diffusion-weighted imaging and has corresponding low signal on the ADC. So what I want to highlight here is that we can use diffusion-weighted imaging as kind of an alternative to contrast-enhanced images to detect abscesses. And I think it is actually very helpful. Another complication of osteomyelitis that we always want to look for is this case. So this is a patient with acute osteomyelitis of the distal tibia. When we look in this area here, instead of seeing just ill-defined edema, we're all of a sudden seeing a very focal, rounded signal. And that is important to recognize that this is beyond just your typical osteomyelitis. This is an intraosseous abscess. And so if you have an intraosseous abscess or Brody's abscess, you want to put that in your report. Anytime you hear yourself saying the word abscess, that's very important. Orthopedic surgeons are listening very carefully to that to decide if they need to intervene and drain that abscess. Now, we talked about diffusion-weighted imaging. This case actually did turn out pretty well, had high signal on DWI and low signal on ADC. But I will say that I think it is a little bit trickier in bone to use diffusion-weighted imaging. But I still tend to just look, but bone tends to have more artifacts. So for abscesses, I think really want to highlight that when you have a PEDS case of acute osteo, you want to look for abscesses. And I have in our template that we're looking for intraosseous abscess, subperiosteal abscess, and soft tissue abscess. And I always tell the residents, make sure that you don't see those things and go look for them. Because if you have an abscess, then it may require drainage. And this is a little bit different than on the adult side. Diffusion-weighted imaging can help diagnose abscesses. Abscesses will have restricted diffusion, high DWI, and low ADC signal. And I believe it can be used as an alternative to contrast. And that's what we do in order to have more minimally invasive imaging for children. In last case, I want to show are some findings of chronic osteomyelitis. This patient actually presented with no history of acute osteo, but had a lot of things going on here. You can see, first of all, a subperiosteal fluid collection of the distal femur, massive bone marrow edema. But when you look at the T1 image, we see a lot of hyperestosis, cortical thickening, and in the center of that, we see this funny little linear area of bone. And it doesn't look like much, but this is a very important finding to recognize. This is a sequestrum. And a bony sequestrum is a small focus of dead bone within a region of typically chronic osteo. And it can be a nidus for continued infection. So if you look for it and you find a little piece of bone, it's usually a sclerotic area, CT is really good for this as well. You want to point that out in your report because they typically will have to surgically debride this area of a sequestrum in order to prevent ongoing infection. That's all I had, and thank you all again.
Thank you, Jonathan. We have questions here at the chat, in the chat. I know some of them you have already answered, but I will read it out loud. So first question is flaring the same as metaphysio equivalent sign to Sergio? Do you want to answer that, Sergio? You're muted.
I thought that it's not a synonym, but it does occur at metaphysio equivalents which are bone cartilage interface similar to those of the metaphysis.
Second question is also to you. Do you routinely use CT-like imaging in PEDS aside joint imaging?
Yes, at the Children's Hospital of Brasilia, it's part of the protocol since January of 2024.
Hillary, do you want to ask your question to Catherine?
Sure, Catherine, it's kind of long-winded. I said that the synovitis and hyperemia result in accelerated maturation and epiphyseal enlargement, but I wondered, why does it cause squaring? Is that just an optical illusion on the conventional radiographs? It seems that on the MRI that you show both in the wrist and the knee, that we don't see those squared contours.
Yeah, I think it's a great question. I have not seen anyone really give a why in the many articles that I have read. I guess it would be, be an interesting thing from a pathology standpoint to see, but it's probably not feasible most of the time. I mean, these patients are not having any kind of surgeries or excisions, and most of them are not deceased. So I don't know the answer. It may be just, it may be something that we see on radiograph that really isn't anything more than just more of the bone is ossified, making it look more squared. I don't know.
I mean, building on that, I see a couple of people among the participants who are, nearly as old as me. And I know that when I was in training, I mean, they talked in the knee about squaring of the intercondylar notch in the knee and the inferior margin of the patella. And I was told by a pretty famous mentor in fellowship that that was nonsense, that was projectional because the kids had synovial hypertrophy and limited extension, and that distorted the appearance. I don't really know what's true. And then just, you very nicely showed the side-by-side difference in the wrist, and it was powerful. But I mean, I was taught that if you really knew what you were doing, you didn't need to get bilateral comparisons. Do you do this routinely?
No, I mean, this was, I wouldn't have said necessarily they needed it. It was only how, this was actually an outside consult that came to us. And that's how it came, as bilateral hands. So yeah, I don't know if orthopedics, wanted it, or they weren't comfortable with kids. Maybe it came from an adult orthopedist who kind of wanted that side to side to look for differences, but often
And it
we
was
see it
striking. You
unilateral.
wouldn't know that there was the accelerated maturation necessarily in the screening radiographs without it.
Yeah, I think it's very helpful. I think you have to be pretty tuned into it otherwise, but yeah, in this case, it was a nice example.
And I know you're doing the research on the fat suppressed sequence to obviate the need for intravenous contrast. I know that on fluid sensitive sequences, you often can't tell the difference between joint fluid and thickened edematous synovium. But usually I think I can on T1 weighting. Have you looked at that?
Yeah, so there are other sequences you can use, I think. This one I had seen an article about, so I sort of was trying to validate it in children. They'd used it in adults specifically for synovitis, but I agree. I think some of our FSPGR gradient echo sequences where the fluid and the fat are suppressed, you could probably use those as well to see the synovium, as long as you have some degree of fat and fluid suppression. I've been able to see it on gradients. I haven't specifically used a T1 fat suppressed.
No, I'm just talking about conventional T1.
Oh, without fat suppression?
Yeah.
Well, I feel
I mean,
like
maybe nobody's doing that routinely, but it's great, especially if you're looking for infection versus inflammation, to have a true T1 weighted sequence, in my opinion.
Yeah. I think that what I've noticed is when the fluid is dark and the synovium usually without fat is kind of the same signal intensity on the T1 without fat suppression. I have not noticed it.
Okay. So there are a couple more questions for you, Catherine. Dr. Al-Hiari asks, how can you differentiate enthesitis in ERA from SPA?
Yes, well, fortunately, I don't know that we necessarily have to say that. I know that the case that I showed was clinically diagnosed as an ERA form of JIA. So ERA is sort of a heterogeneous clinical group of children who have predominantly enthesitis. But if they have spondylitis associated with this, if they have spinal involvement, a lot of back pain, then it might be considered a spondyloarthritis clinically. So this patient, they did certainly have sacroiliitis, but didn't have as much of the lumbar spine involvement. So I think that's what differentiates it. And we don't necessarily have to come down hard on one of them other than describing the predominant involvement of the entheses, very little joint disease, and sacroiliitis. And then the clinicians kind of funnel them into one of these categories. So you have the enthesitis predominant arthritis, you have juvenile ankylosing spondylitis, inflammatory bowel disease associated arthropathies, and those are kind of the big three categories of ERA. So I'm not sure we necessarily always need to differentiate that, but certainly if there's spinal involvement, I would consider spondyloarthropathy.
So building on that question, Dr. Eduardo Brown asked, do you do whole body MRI for ERA and SPA? And if yes, he wants to know your protocol.
Yeah, so we do not get asked to do this. We do have a CRMO protocol, whole body. We do those a lot. We have not been asked to do whole body MRs for JIA yet, but it might be coming. I can share my CRMO protocol, but I think those are pretty well published out there.
Okay, and the final question in the chat is for Dr. Samet. I actually can't pronounce the last name. From Dr. Baya is the first name, who asked, hello, do you use MSK RADs while interpreting infection? I think that's referring to one of these, like RADs classification systems.
Right. I answer no. I think I was actually a part of that paper as one of the readers. It was a recent article on MSK infection RADs that just came out, trying to come up with a system of scoring for mainly adult infection to give like a number of how likely certain things. And so I don't know that that's mainstream quite yet. Even in the adult world, in peds, we're always kind of like the second people to get scoring systems. So the answer is no, but I do think I try to systematically report on all of those things I mentioned. So osteo, yes or no, subperiosteal abscess, yes or no, intraosseous soft tissue abscess, just kind of very systematically going through it. Because when the team is getting the report, they're trying to decide, can we just do IV antibiotics, or do we need to consult IR or surgery to do a debridement? And so they're looking for those words. And I think as long as you're systematic in your kind of search pattern and reporting, then you give them all they need to know for the case.
Makes a lot of sense. Eline,
Yeah.
any other questions? Or
No.
anybody else from the group?
Okay, thank you all for tuning in. Next session will be held on October 25th and will focus on infection. See you then. Bye. Thank you very much.
Thank you.